Hello, my name is Aman Chauhan. I'm one of the medical oncologists at University of Kentucky, and I direct our Neuroendocrine tumor theranostics program at Markey Cancer Center. This month, Carcinoid Cancer Foundation has asked me to be the NET expert of the month and address some of the questions from our neuroendocrine tumor patient community. I'm truly honored, and thank you, Carcinoid Cancer Foundation, for this lovely opportunity. So let's get cracking. First question. After using capecitabine temozolomide for about 7 months and there was no regression in liver with innumerable tumors, what other options are available for patients with grade 3 well-defined NET? To be honest, grade 3 well-defined NET is somewhat challenging patient population to treat for multiple reasons. One of the reasons being the grade 3 well-defined NET is a relatively new subtype of neuroendocrine tumor. Because it is a relatively new entity, we do not have a lot of prospective clinical trials helping us figure out what's the best frontline, second line, and third line treatment options. Also, grade 3 well-defined NET is a very heterogeneous patient population, and the clinical behavior of these tumors can vary markedly based on Ki-67 index and other factors. So some of the patients with grade 3 well-defined NET can have very aggressive clinical course, while others can have a clinical course more akin to a grade 2 well-defined NET. Having said that, capecitabine temozolomide is a very reasonable frontline treatment option for well-defined NET, especially pancreatic well-defined NETs. However, if for some reason we have to stop CAPTEM, either because of progression or lack of effectiveness or side effects, some of the other treatments to consider as second, third line would be either cytotoxic chemotherapy, especially if patient has very aggressive progression or visceral crisis, then can consider platinum-based chemotherapy. If the patient's having a more relatively slower progression and has a good uptake on copper or gallium-68 dotatate scan, suggesting a high prevalence of somatostatin receptors on the tumor, then PRRT can be a very lucrative option. In fact, there are 2 clinical trials currently evaluating effectiveness of PRRT in high grade or grade 3 well-defined NETs, one of them being NETTER-2 and the other one is COMPOSE study. So if you have access to these clinical trials, I definitely encourage you to consider them, and that would get you access to PRRT based agent as well. Besides that, I also tend to get next generation sequencing to screen for targetable mutation, and also to look for tumor mutation burden, and based on the TMB status, we might be able to leverage some of the immunotherapeutic treatment options. So I encourage patients to seek clinical trials for this rare entity. Besides that, PRRT, certain cytotoxic chemotherapy could be our other treatment options. All right. Next question. What is the best treatment plan for poorly differentiated neuroendocrine carcinoma of prostate following radical cystoprostatectomy, but with evidence of local relapse within 2 months after surgery? There is also an underlying CHEK2 germline mutation, and Ki-67 is about 90%. For poorly differentiated neuroendocrine cancer, it is not unexpected to see early relapse, and that's why this is a very, very aggressive disease entity. Even when caught early, and a lot of time we do curative surgery or curative intent chemoradiation, many patients would unfortunately relapse quite early. In event of relapse or metastatic disease or unresectable disease, my go-to treatment for frontline therapy for poorly differentiated neuroendocrine carcinoma is platinum-based chemotherapy, carboplatin etoposide or cisplatin etoposide, especially when we have a very high Ki-67 tumor, index tumor. However, this patient also have a CHEK2 germline mutation for subsequent lines of therapy, Patients should consider looking for target therapy trials, especially with check to mutation. There could be role of PARP inhibitor. So I would highly encourage patients to seek tertiary care centers and to look for clinical trials utilizing PARP inhibitor for this particular kind of mutation. Besides that, I often use irinotecan based chemotherapy, capecitabine temozolomide. I also often use immunotherapy based treatment, ipi-nivo based on SWOG DART 1609. However, the data is very limited for role of immunotherapy. So those are some of my go-to agents for subsequent line of therapies for poorly differentiated neuroendocrine carcinoma. Okay, next question. Why does octreotide work for carcinoid crisis during surgery and lanreotide does not, since they are so similar? And also, are NET tumors in ovaries vascular? That's a very interesting question. Now, right off the bat, there is some ongoing debate regarding role of octreotide in general for management of carcinoid crisis during surgery. There is a growing school of thought that octreotide really doesn't help in preventing carcinoid crisis. And then there's another school of thought where we routinely use short-acting octreotide to prevent as a prophylaxis for carcinoid crisis during the surgery. So the pathophysiology of this disease is still evolving, and there's some data emerging, especially from Dr. Palmier's group, suggesting that we might not be able to predict who are the high-risk patients, and does adding prophylactics octreotide helps at all. So you will see a dichotomy in the way we practice throughout the US. Some institution would give prophylactic octreotide before surgery and others would not, and only time would tell what's the right approach. However, coming back to your question, why do we give octreotide and not lanreotide? Now, lanreotide is the long-acting depot formulation, which is injected deep subcutaneous tissue from where it's slowly released throughout the month. However, for a carcinoid crisis during manipulation of tumor or surgical procedure, there is a sudden surge of serotonin, and the octreotide that is needed at that time to decrease the secretion is a short-acting octreotide, and that's why we use octreotide, the short-acting version, either through as an IV infusion during the procedure to circumvent that acute carcinoid crisis situation. Regarding the question, are NET tumors in ovaries vascular? To my knowledge, I think they are. And another unique aspect of ovarian vasculature is that it bypasses liver. So the patients with ovarian NET can have functional or carcinoid syndrome even without having liver mets. Usually the mid-get NET patients tend to have carcinoid syndrome when they have a decent amount of liver burden in the disease. However, a small exception to that is the ovarian NETs, because some of the vasculature bypasses liver and can cause systemic exposure to serotonin and cause symptomatic functional disease. Next question. Pancreatic neuroendocrine tumor since 2011. What are your thoughts on belzutifan study for PNETs? The agent is under investigation. I am not privy, I'm not involved in the drug development of belzutifan, so I would refrain from commenting on that. We will wait for more data on that. What are the side effects of PRRT? Is it advisable for patients who have also been diagnosed with osteoporosis? To my knowledge, I do not think there is link between osteoporosis and PRRT. If in future we learn something new, we can certainly screen for it. But as of now, I do not think PRRT puts the patient at risk of developing bone health disease or osteoporosis, osteopenia. What are some of the common side effects of PRRT? So there are short-term and the long-term side effects. In short-term, PRRT can cause myelosuppression, so acute marrow-toxicity, low blood counts, especially platelet counts, something that we watch closely. But besides platelets, also hemoglobin and white blood counts, especially lymphocytes and neutrophils. During clinical trials for PRRT, we were also worried about potential for nephrotoxicity or kidney problems. However, in real world, we've been now using PRRT quite a bit since its FDA approval, and we have not really seen that the nephrotoxicity concern has been a big concern in reality. It's very well tolerated and has rarely caused any issues in terms of renal functions. Also in clinical trial, we used to see a lot of nausea and vomiting, and that perhaps was because of the amino acid used in the clinical trial, the NETTER-1 study. In real world now, we are using a much better formulation of amino acid, which is way less emetogenic, and we are not seeing major nausea and vomiting issues, maybe barring a day or two. So really in reality, PRRT, especially lutetium-177 dotatate therapy, is very well tolerated. Now, one of the big concerns about any PRRT agents is long-term side effect potential. Although as of now, we have 5+ year follow-up data on NETTER-1 study, and the rates of leukemia, MDS are about 1 to 2%. However, there is some growing retrospective data suggesting that if there is previous exposure of cytotoxic chemotherapy, especially alkylating based chemotherapy like Timodar based treatment, KIPTEM, there could be an increased risk of these long-term myelotoxicities and MDS and leukemia risk. This is yet to be studied and validated in more prospective long-term trials. However, we should always be concerned about long-term PRRT toxicities in patients who have had a prolonged exposure with alkylating based treatment in the past. All right. The last question for this session: can carcinoid cancer show up as skin problems? Patient is reporting some bumps, not really a rash, and is asking should she seek a dermatologist appointment. Carcinoid syndrome typically present as flushing, wheezing, diarrhea, but there are a host of other clinical manifestations, achiness, fatigue, etc. To have what we call a papular rash, not a flat but more bumpy rash, it has been reported as a paraneoplastic syndrome, some sort of granulomatous rash. So I would definitely advise, if this is a new problem, especially post-diagnosis of carcinoid syndrome, to seek a dermatology appointment. They do have that advantage of having capability to sample the tissue, so take a quick skin biopsy and confirm what's really is going, and they truly are expert in the cutaneous manifestation of disease. That's why neuroendocrine cancer management is truly a multidisciplinary management, and it's a teamwork. So I would encourage you to seek an opinion from dermatologists to see what's really going on, or whether it is linked to carcinoid syndrome. With that, I would conclude this section, and shortly we will come out to the next session. We have more of these fantastic questions submitted to us by neuroendocrine patient community. Thank you.